Hello, we'll just take a minute for everyone to settle. Okay, let's kick off. Hello, welcome everyone. My name is Dr. Harm Hollander from the AHDC. Welcome to this night. We are pleased to have you here tonight for a little bit of general discussion and philosophizing on this subject. We're always pleased to see the great interest in these topics. We would like to begin by acknowledging the traditional custodians of this land on which we meet today around Australia. I would also like to pay my respects to elders past, present, and emerging. Secondly, we'd like to thank our sponsors. It is because of our sponsors that we can put on events like this and do other publications and other work through the AHDC. The foundation partners, In Vitro Technologies, Katingi, and Enware. Our industry partners, IPG and Steris. Tonight's topic is inclusive design, which I remind you is not aspirational, it's fundamental. This webinar will explore the question, how can universal design support inclusion and improve well-being in healthcare settings? We need, as a profession and as an industry, to engage meaningfully with the community, amongst ourselves, and develop responses that will create access and safe spaces for everyone. The places we create should reflect and include the voices of many different people. And this is particularly true for essential services such as healthcare. Extensive research confirms the benefits of well-designed places and the positive impact of design on our lives. The connection between design and neuroscience, health, well-being, and human behavior is evident, and it is important that this evidence base informs our decision-making about the shape, nature, and function of our cities, buildings, and landscapes. Hassel's research, equal access is not an optional extra, reports that to create a truly inclusive environment, designers should stretch beyond the regulatory compliance and consider comfort and wellness, all abilities and gender, and understand the local context, traditions, and heritage to develop a genuine relationship with stakeholders to ultimately create places people love. In my own words, in teaching at university, I often describe architecture must serve as a delight. And if we don't have that, we are failing as designers. I'll next move on to CPD points. This will be true of various professional bodies, but me being an architect, I'll focus on architecture, but I know that the same is true for project managers and engineers. We can all claim continuing professional development points for today's events, depending on the particular context of your legislated or body representation. The details can be found in the event information. For architects claiming formal points, a link is provided in the registration email. Just some housekeeping before we start. I would like to share some housekeeping rules. During and after the presentation, attendees will be invited to send their questions using the Q&A button at the bottom of the screen. Sorry, I've lost my sheet here. And we will moderate them and go through the questions afterwards. So that's after the presentations, and we'll turn it on then. We encourage you to stay online after that for further informal discussion and some mingling in a more informal settings. This event is also recorded and will be available in the next week on our website for members access only. The discussion session which follows this will not be recorded. To introduce the speaker today, I said to her previously, you don't really need an introduction, you're well known. But for those of you who don't, Leanne is currently with Hassel's as a global health sector leader. She has a background in both nursing and design and more than 20 years working on healthcare projects in Australia and the UK. With her experience, this has enabled her to develop an in-depth understanding of human behaviour and the need for a holistic design response at creating environments for health and well-being. I present to you Leanne. Thank you.
Sorry, okay. Can everyone see my screen there? Thanks, Harm, for that introduction. I would also like to acknowledge and pay respect to the traditional owners as the original custodians of the land upon which we work. We honour their elders past and present, whose knowledge and wisdom has and will ensure the continuation of cultures and traditional practices, and that sovereignty has never been ceded. It always was and always will be Aboriginal land, and I acknowledge the ongoing connection of First Nations people to their country. I think in context of today's discussion, I'd also like to acknowledge the traditional knowledge systems, including medicine, passed down through generations of First Nations people, ensuring sustainability of lands and waterways and the health of community, and the impact of colonisation and the removal and disconnection of people from their lands, and the major impacts on those traditional medicine practices. In embracing the principles of inclusive design, we really should be striving to create today's modern healthcare systems that are accessible, culturally sensitive, and responsive to the needs of all individuals, including those from First Nations communities. At Hassel, we are working to embed First Nations perspectives in our design processes and promote our industry to the next generation of First Nations designers to create places that people love that are authentically connected to country. Sorry, my mouse is really sensitive. And we really do believe that the world's best places are always more than the sum of their parts. They go generously beyond the brief to create a better future. We believe in the impact of great design that is engaging, enriching and enduring, and the design that adds beauty and value to the world. I'm delighted to speak to you about the importance of inclusive design in healthcare, but I would also like to acknowledge Michaela Sheehan, who led this piece of research with Hassel. It was named Equal Access is Not an Optional Extra. Unfortunately for us, Michaela has taken up a great opportunity as a researcher now in the education sector, and she's no longer with Hassel. So that's why I'm presenting this evening. I'd also like to acknowledge that we're all at different stages of our careers and knowledge of this topic. So for some, this may not be new information, but perhaps an opportunity to reflect upon what has been done in the past and consider how to continue to refine your understanding of inclusive design. The focus also tonight will be on patients, but we also know that equitable access and inclusivity for healthcare staff is equally important. I'll also reference a number of organisations in the presentation, and I would also recommend that you look further at this information at a later date. Universal design and inclusive design are terms that are often interchangeable, but I think they can be differentiated with the following definitions. Universal design focusing on creating products, environments and services that are accessible and usable by as many people as possible, regardless of their abilities or their disabilities, and it aims to accommodate the widest range of users. While inclusive design goes beyond accommodating a wide range of users and strives to actively include and involve underrepresented or marginalised groups in the design process. It recognises the importance of diverse perspectives and aims to address specific needs and challenges faced by different individuals or communities. So in the context of healthcare, inclusive design is crucial to ensure equitable access to services and the provision of quality care for everyone. When thinking about inclusive design, we should be considering what processes will bring about spaces that really genuinely support the flourishing diversity of people. And what are the relationships between human variety and neuro and biological complexity, and how do we facilitate conversations for problem solving and the design of built spaces? Dr. Manisha Amin is the CEO and a strategist at the Centre for Inclusive Design, and her mantra, "Nothing about us without us," suggests that the stakeholders in the design process should be as diverse as possible and include individuals who have lived experience and who are the extreme users of the space which we're designing for. And also that design considers the full range of diversity with respect to ability, language, culture, gender, age, and other forms of human differences, which means more people are included. She also states that we have a role to play by designing, investing, and legislating with difference in mind, so that a design process is inclusive, becomes a standard practice. And really, I like this description by the International Federation of Interior Designers. Good design inherently supports a totality of health and wellbeing for users, the wider community, and the planet. And good design also delivers life-affirming and transformative possibilities. And Hassel's research, Equal Access is not an optional extra, states that great design should be judged on whether it achieves an inclusive environment. It doesn't mean that every individual's needs are met, but by designing spaces with a choice of settings, including diverse user groups early in the design process, and applying consistently high standards, design can embrace everyone on equal terms. Accessibility laws and building codes are a limited indicator of the potential for design to facilitate independence, participation, and well-being for a growing proportion of people. We now live 30 years longer than people did 100 years ago and survive illnesses and injury at record rates, and most of us will experience at least periods of functional limitation over the course of our lives. So inclusivity is not aspirational, it is fundamental. The places we create should reflect and include the voices of many people we encounter in our lives every day. This is particularly true for essential services our communities expect and need, like healthcare. As part of Hassel's research, we asked how we design hospitals where everyone feels included, and ultimately the answer is to give people choice. A number of organisations, including the Institute of Human-Centred Design and the Victorian Health Building Authority, have inclusive or universal design principles that establish a language for explaining the characteristics of universal design, and they're common around the words with slight modifications around equitable use, flexibility in use, simple intuitive use, perceptible information, tolerance of error, low physical effort, and size and space for approach and use. However, for our report, we've referenced the Centre for Inclusive Design and Environmental Access at the University of Buffalo, who in 2012 developed 8 principles of universal design, which encompass what we mean by inclusive design. And these include comfort. Are actions like reaching for a handrail within desirable limits of a body function? Body fit. Does the design accommodate a range of body abilities and sizes? Wellness. Does the design promote health? Social integration. Are all groups treated with respect? Understanding for things that need to be operated. Are the uses clear? Personalisation. Are there opportunities for personal choice? Cultural appropriateness. Is the design respectful of cultural values? And awareness. For example, is signage easy to interpret and even see? We know that space is just one part of the inclusion equation. Education and training in cultural competency, workplace policies, and anti-discrimination legislation can contribute to a more inclusive environment, and our focus is how to design the physical environment to cater for the broadest possible ranges of need. So inclusive design has been evolving, but the current approaches generally relate to 3 groupings that we've identified. Different abilities, including age, physical and neurological cognitive decline or disability, medical conditions and neurodiversity, gender and sexuality, and faith and culture. Each group has its own unique characteristics and histories, but at the heart share common goals: dignified, comfortable and equitable access to spaces and places for all. The sheer diversity of any population makes the task of including everyone in every way impossible. The Centre for Architecture and Built Environment, otherwise known as CABE in the UK, points out an inclusive environment does not attempt to meet every need, but offers choice where a single design solution cannot accommodate all users. Oops. In 2001, following a 10-year global study, the World Health Organization issued a new definition of disability. It addressed two competing definitions of disability: the medical model that saw disability as a feature of the person and focused on correction of that condition, and the social model of disability that defined disability as a social construct. They developed a biopsychosocial definition that focused on function, referring to body functions, body structure, activities and participation. They also focused on the interaction of the person with a functional limitation on their personal and environmental context. So in context matters, and the environmental context offered a powerful opportunity to minimise disability as a negative consequence of that action. Now, with longer lives, difference in ability has increased to become a predictable human experience, at least episodically for everyone, unfortunately. As a demographic category, disability is a human characteristic similar to race or gender. An individual may or may not choose to choose it as part of their personal identity. For some, there's a sense of community that that can be a source of pride and strength. For others, especially those with non-apparent conditions, there's less of a reason or less of a feeling to disclose that disability. Some really interesting stats. In 2018, the Centre for Disease Control in the US released data for disability that basically stated that 1 in 4 adults live with a disability. In the UK, 34% of the adult population has a disability, and in Australia, it's around 18%. And these vary accordingly, depending on the definitions, but they are significant and they are increasing worldwide as the populations age. Accommodating people with physical disabilities and medical conditions is the very purpose of our hospital setting. Accessible circulation and amenities are incorporated by law and for practicality in healthcare building standards, as are considerations of patient size, such as bariatric beds and rooms, age for including furniture and equipment for children and the elderly, and mobility, tactile indicators for the vision impaired. The general effects on patients of environmental factors such as lighting, views, art and acoustics are all well researched and proven, but there are circumstances where individuals may not benefit from uniformity or at all from these things. For instance, high levels of lighting that help to minimise medication errors can actually be distressing for patients with some eye conditions. And that's why choice is important. Oh, gosh. More recently, researchers have begun to explore the effects of environmental design on those with neurological variances, such as autism and dyslexia, as public awareness and diagnosis also increase. Judy Singer is an Australian sociologist who coined the term neurodiversity in the late 1990s. And neurodiversity refers to the virtually infinite neurocognitive variability. It points to the fact that every human has a unique nervous system with a unique combination of abilities and needs. And at least 1 in 10 people are neurodivergent and are hypersensitive to sensory constructions of space. So when confronted with unexpected, new or multisensory information, this hypersensitivity often causes extreme distress. Neurodiverse people can struggle with organising and making sense of space. They can find it hard to prioritise the sensory information around them. Large, expansive spaces can be overwhelming and difficult to decipher due to excessive visual stimuli, causing confusion about where to go and what to do. And often people with neurodivergent variations prefer routine and order. Transitioning from one activity to another or from one space to another can present challenges, plus situations or locations can promote anxiety on arrival if the space isn't legible and well-defined. The threshold moment of entry can make some people feel overly exposed, and if there's transitions between spaces are also abrupt, there's a risk that this can also escalate anxiety in a neurodiverse person. One study into designing health facilities for young people with autism spectrum disorder concluded that sensitive environmental design was particularly important in the emergency department because of the volume of activity, noise, light, and visual clutter. And this research suggests that to mitigate these sensory triggers, designers should really be considering providing quiet waiting spaces, private patient rooms, dimmed lighting, and distraction items. Similarly, people with dyslexia, estimated to be up to 10% of the population, that's in Australia, will benefit from inclusive wayfinding and signage design. Font selection in signage is crucial. Pictograms are also useful and have the added benefit of communicating important information to patients who don't speak the local language. While designing for age and ability differences is well advanced, issues of gender and sexuality are more sensitive and generally less defined, particularly when coupled with faith and cultural practices. The LGBTIQA+ community have campaigned for minority and marginalised groups and contribute to public discourse on the right for everyone to feel safe and comfortable in public spaces. Toilets are often first on the agenda in discussions about inclusive design, and I'll speak a little bit more about that shortly, but it should be noted that there needs to be more than just a discussion around public amenities, including safety and security, and the use of other clinical and non-clinical spaces. The issues of sexuality and gender in private spaces, including toilets and bathrooms, however, are critical considerations, specifically language, what do we call these spaces, number, how many do we need to provide, and category, how do we split different genders and identities without excluding anyone. Where space is tight, as it usually is in hospitals, minimum requirements are often the default position. The National Construction Code of Australia stipulates male and female toilets plus unisex accessible facilities. But there is growing acceptance of the need to take a more inclusive approach to gender. Choice is the key. Where possible, hospitals should provide separate male and female and all gender facilities. Rainbow Health Australia is a program supporting LGBTIQA+ health. Notes that while these communities have only recently developed positive definitions of who they are, there is still debate about these issues within and outside the communities. Consensus may not be possible, but it's important for designers to be aware of the need to consult with the intended user groups. All gender appears to be the least contested terminology, as it's more general than unisex or gender neutral, but some inclusion advocates prefer an entirely gender-free approach, where toilets are simply indicated by a pictogram. When gender neutral, all gender or unisex toilets are well-intentioned to include previously excluded groups, the unintended consequences of this approach is that those labels can alienate others, and namely women and some men who value the privacy of gender separation of toilets, where safety, hygiene, cultural or religious reasons. Choice is important. The Hassel team have recently developed the preliminary designs for a women's and newborns facility, and consideration of a non-binary approach to care, including the birthing suite, was critical in supporting the diverse community. And this included same-sex couples, surrogates, and non-binary persons' pregnancies and birth. At this stage, a strategy hasn't been agreed, but there has been acknowledgement that ongoing discussions are required to ensure inclusivity of all the users. An interesting report by the Victorian government from 2018 outlined that trans and gender diverse people are one of the most vulnerable and high needs groups in Victoria, and they experience very high rates of mental illness, stigma, discrimination, and disadvantage. So co-design really is critical to ensure that the needs of the LGBTIQA+ community are considered in our healthcare facilities. The third type of inclusive design response in our research relates to the social practices of faith and cultural groups, including migrants and First Nations communities. Cultural competency of staff is critical to making people feel comfortable, but this must be supported by spaces that enable cultural practices, like large family waiting areas or patient rooms, prayer rooms and multi-faith spaces, and also death and birth ritual spaces. In Australia, the greater burden of disease for Aboriginal and Torres Strait Islanders compared to the non-Indigenous population underscores the need for specific policies that improve the health of First Nations people through increasing cultural safety. Indigenous Australians often don't feel safe in hospitals, and if an environment doesn't feel safe, it's not. We can learn from Aboriginal and Torres Strait Islander peoples on how to design healthcare facilities that treat the whole person beyond the medical presentation. Hospital data shows that Indigenous Australians are more likely than non-Indigenous Australians to leave hospital without completing treatment. 32% of Indigenous Australians who do not access healthcare when they needed it indicated this was due to cultural reasons, such as language problems, discrimination, and cultural appropriateness. Research of patient rooms for First Nations people showed preferences for a 2-bed patient room, a balcony rather than a window only, Indigenous art, view of the park rather than an urban environment. Important factors in these preferences are cultural recognition and the desire for company of family members and the connection to their life outdoors. This is an image here of the Karratha Health Campus in Western Australia, which was designed by Hassel, which really does create a connection between the hospital and the surrounding environment, inviting that interaction and promoting health and providing welcome amenity for the entire community and to increase that cultural safety. Within the building, there's a 3-volume landscape courtyard at the hospital entries, which provides a lush and calming green vistas for relaxation and respite. Externally, a series of these landscape moments are shaded by trees or shelters and offer distant views to the Burrup Peninsula and also the Karratha Hills. These garden spaces offer patient, staff and visitors a moment to escape and to take in the landscape and opportunities for outdoor health consultations, which has also proven to reduce stress and improve health and clinical outcomes. Overall, the project reflects a collaborative journey and underpins a genuine desire to understand place as well as serving the community. And I just wanted to touch on the cost myth as well. Inclusive design is a cost efficiency and not a burden, as it assists many more people than just those that it's been designed for. There are countless products and services we all benefit from that have been designed for disabled users, like the electric toothbrush, the pinch screen Zoom on mobile phones, which was designed for the vision impaired. Subtitles are used and appreciated by all people. Ramps were designed for wheelchairs, but anyone pushing a pram uphill understands their value. PwC have estimated that the most inclusive design innovations are likely to benefit up to 4 times the number of people initially targeted. So with the quadrupling the audience in mind, an all-gender amenity, for example, that meets accessibility standards, provides a comfortable experience for a wheelchair user, a stress-free public toilet option for a transgender person, and allows a dad to help his young daughter wash hands, that's certainly a value-added design. The Coles supermarket in Australia have introduced an autism spectrum-friendly low-sensory quiet hour in several locations. Reduced noise, lighting, and other in-store distractions are really attracting many users beyond the initial target group of shoppers. And Singapore's Changi Airport have got a quiet terminal initiative, which was launched in 2018, and really is a game changer for the weary traveller. Imagine if our EDs and our ICUs also looked at this as an opportunity for patient health and wellbeing. Quite apart from the convenience of and the moral imperative for inclusive facilities, design that excludes users is now a legal and financial liability. The landmark legal case, which I'm sure you've probably all read about in Australia, has ruled in favour of a vision impaired man who was discriminated against through the design of a Queensland hospital. And this case really illustrates, I guess, the difficulties of accommodating all users. Strong colour contrast in this case is necessary for wayfinding for the vision impaired, but in other circumstances, it's potentially argued against for the benefit of the neurodiverse user. Tactile indicators on the floor will aid wayfinding also, but these are often problematic for many different types of mobile equipment required in the hospital setting. All of these points really point to the importance of understanding your users and engaging as many different perspectives as possible in the design process to minimise design risks and unintended consequences. Consultation really is this key to inclusive design. Right from the outset of any project, particular attention should be paid to those who are likely to be overlooked or whose views are also less likely to be accommodated. The Office of the Victorian Government Architects highlights that good design is critical in creating high quality buildings and public spaces that are fit for purpose and adaptable to changing needs, engaging and create a strong sense of place, able to engender civic pride and wellbeing in the community. It should also be inclusive, culturally rich, diverse and sustainable, environmentally, economically and socially, and plus provide an enduring legacy in the built environment. If we're able to achieve inclusive design within our hospitals, we need to go beyond merely removing the physical impediments and look to actively embrace the social, psychosocial needs of facilities consumers, staff, patients and visitors. And for best outcomes, hospital and healthcare services should be grounded in authentic partnerships that involve co-design and be informed by the lived experience of users. At HASL, we're exploring inclusive design through specific consultation groups on projects ranging from hospitals through to railway stations. As much as legislation and standards help to guide architects and provide consistency, they cannot replace local knowledge and the experiences of real people in real places. In the design of hospitals, it's important for designers to understand, to educate and to work with the health facility users to deliver the best outcomes, and in that process raise the level of both physical and social well-being. And consultation through the early stages of design may take several forms. It could be stakeholder surveys or interviews, co-design workshops or design reviews, cultural engagement, gender or social audit in the early stages of design, either with an expert or a consultant or user groups, or ideally both. But ideally it's at the start of the process. And design excellence emerges through genuine relationships and a deep understanding of our stakeholders. And great design really should be judged on whether it achieves an inclusive environment. It does not mean that every individual needs are met exactly, but by designing spaces with the choice of settings, including diverse user groups early in that process and applying consistently high design standards will meet the needs of all users. Design can embrace everyone on equal terms. Thank you very much.
Thank you, Leanne. I'm always thrilled to be a part of a upping the bar exercise to challenge us. This topic certainly warrants a national dialogue and discussion. This is part of it. We're going to open up Q&A right now, so put your questions in the Q&A. I just also suggest that if you have an observation more than a question, start the question by saying observation colon and make your observation, and then we can all read that too. My first question to you, Leanne, without falling for the temptation that equitable access is all that inclusive design is about, our minds goes to the NCC and ever-changing and upping of the legislation in that regard. Do you believe that the prescriptive methodology of the NCC actually is more limiting or restrictive, or is it an opportunity in achieving universal access?
I think it's probably the first step. I think it is absolutely essential, and there's a lot of work that goes into determining the requirements and the legislation around the NCC, and certainly it has been highly important for disability and accessibility in healthcare, as one example. But I think we need to be mindful when we're looking at these that it's only one part of the universal design or inclusive design process, and that, as we've talked about tonight, there's so many more elements to it that need to be considered. And I think we've moved so far in terms of accessibility, but there's all these other elements that need to be considered. So I think absolutely essential, but we need to just think of it holistically and think beyond the requirements. And as a good designer and good design outcomes, that should be what we should be achieving.
Yeah, as an extension to that, though, the NCC has a very solution-focused methodology. Say, this is what you should do, rather than describing the issues that surround it and the potential other solutions. Do you think that is beneficial?
I think, a lot of people, and I think it's probably similar, dare I say, to the Australian Health Facility Guidelines as well. It's a great place for people to get an understanding of what the requirements are. I think, but they're a moment in time document as well. And I think, through innovation and testing and discussions with, the actual end users of the space, there is possibly opportunity to go beyond these documents, as long as we are benefiting the majority of the users. And I think that this is what, I was trying to get at tonight, was that you're not going to achieve everything for everyone in every instance, but if you can support the majority of users, then that's the best outcome.
Yeah, actually, as a supplement to that, you've inspired me. A number of years ago, I was invited to submit to the ABCB on gender-specific toilets or unisex toilets, and I felt there wasn't enough evidence around. But from your description, I'd like to hear more about that evidence to be able to make that submission. Next question, though. What are the lessons learned from other related sectors which could inform better outcomes in healthcare settings? Or do you believe in the healthcare sector could be leading the way in universal design?
Well, I'm a bit of a supporter of the healthcare sector, given it's my area. And I think, we can inform other sectors as much as we can learn from, areas that are progressing ahead. I mean, I think from what we're seeing from Hassel's perspective, our rail sector has really pushed ahead in researching and looking at, evidence around the safety of women in our, rail, kind of in rail spaces and railway stations. And I think there's learnings from that. I think that there's a lot of cross-sectorial kind of learnings, and we should be pushing and doing that. But I think, I think, hospitals are important public buildings, and it is an opportunity for us to be really stretching ourselves and to be really creating spaces that people do feel welcome and safe, and that staff want to be there. And we know that we need to be looking at more and more ways to attract and retain staff. So I think all of those things that we're doing will support other sectors, whether it be rail or education, possibly not residential. But I think, certainly we can be trailblazers for sure. Let's do that as a sector.
Yeah, I agree. Yeah. My final question before I go over to the published questions is, the Architects Accreditation Council of Australia, who determines the standards, the competency standards for all architects, have a new requirement introduced next year for connection to country, and for architects to be knowledgeable and to work within that navigation framework. Are there any, firstly, are there any comments? And to everyone else from other professional bodies, do you have similar things? You might put that down in the observations. Leanne?
Look, I think we're seeing a step change in that authentic engagement and that authentic understanding of connection with country. And I was just speaking with a colleague this evening about the Institute Awards last week, and how it really felt authentic in terms of the conversation about connection to country. So I think as part of the registration process, whether it's on graduation or that point of registration or post-registration, which I believe that all of these milestones will be occurring, is that, it's just so important to bring awareness to it and then gradually build on that knowledge. And that's what I think as a practice we're doing, and we're, developing up competencies and confidence to be able to have our team speak and engage with First Nations representatives in our projects. I think it's also okay to acknowledge that we're on a journey of learning as well. And so this just supports that. I think it will be interesting. Hassel's a big organisation, and we have mechanisms in place to be able to support that training and that, engagement in-house and that journey in-house. But it'll be it'll be interesting to see how the smaller organisations or the one-person practices or two-person practices have the capacity and knowledge to do that. So I think that'll be an interesting space to watch.
Yeah. As I said before, upping the bar all the time. So I was pleased myself to see the opening of the State of Origin match last night with the acknowledgement of country. That was a very hopeful thing for those who saw it. First question here. From your knowledge of research and experience, do you have any suggestions about managing tensions between patients, users, and staff requirements, such as the lighting and vision pathology you used as an example?
Look, I think, in the past, a lot of our consultation has only been with the clinical staff. And so, there's been an expectation that the lighting needs to be able to support, and I touched on this, reducing medication errors, and, basically facilitating good health outcomes by supporting the staff. But I think what we need to be able to provide, as I spoke about, is choice for people, so that if a patient wants to be able to dim the lighting in their room, they've got that ability to do that. We need to think about lighting for safety and, having a way that the elderly or patients who have perhaps cognitive impairment can have night lighting from the bed to the patient ensuite. And we're seeing this developed in a lot of our designs now. But I think ultimately it's just about providing personalisation of space and being able to provide that choice.
And maybe even a patient who can sleep.
That's right. And we know that sleep is essential for well-being and healing. So we need to be encouraging that.
Yes. Okay, we'll move on to the next question. Given the complexity and different needs of the variety of user groups in healthcare settings, do you think the hospital clients are allocating enough time to stakeholder engagement to work through these issues?
I feel that, yes, there is a lot of stakeholder engagement time, but a lot of it is focused on the clinicians. And I think there is opportunity to bring in patient representative groups that are very diverse. I think that's perhaps the area that we could improve upon. I feel like, we typically have a process where we have concept, schematic design, design development, and there's generally 3 rounds of user group meetings in each, and then we get different staff members at different meetings, and it's like corralling cats sometimes, as I'm sure most people on this call would appreciate. But I think where we have had fabulous discussions is where it's a mixed group of clinicians and consumer representatives, and it's not just purely consumer focused, but also just having separate consumer discussions as well is really highly beneficial. So I think we need to get that balance.
Yeah. You mentioned the dichotomy of the use of tactiles for access and the potential negative impact of some clinical users like walking aids, etc. Are you or anyone else listening aware of an instance when you have been able to not use tactiles in a healthcare environment?
Look, I might open that up to anyone else who might know. I don't know. I know I was coming back from the airport and I was watching all these people trying to cross over to get picked up from the Hilton, and they were going over the tactiles, and every single one of them was losing their luggage off the trolleys. And it was just this comedy of errors. Every single person who went over the tactiles lost all their luggage.
Yes.
Because there was no space for them to not use the tactiles. So that's a really interesting one, because I absolutely appreciate the importance of them. But it has implications, and out of that, people were falling over as well. So there's a risk element to that. So I think that's a very tricky question.
I have noticed overseas, like in Canada, for instance, they're much more subtle about the tactile, so it's much more gentle for you, but it's something that the blind can still feel. It's not made for sight. But I'll give you one example of a very easy target is a stair in a hospital only used for staff circulation.
Mm-hmm.
You can easily argue that if there's a vision impaired person on staff, they're familiar with the environment. Therefore, it's not necessarily through tactiles.
Yep. True.
All right. This is, you're deleting questions, Dario. I see. From your knowledge of research and experience, do you have any suggestions about managing? Oh no, we've had that one, haven't we? No? No, we've had that one. Do you have any suggested activities outside formal user groups for engaging stakeholders and collecting feedback from a variety of groups?
Yeah, I think this comes down to this community, open forums for community as well. They're quite interesting, and we often see them as part of like the bigger projects like your PPPs, where we open up for community consultation and we, present designs, and it's a really, really engaging process, and we get so much out of it as a design team, really hearing from the community about what's important to them. And we have these ideas about what we think would be, an activated space or an engaging community element of a hospital. But it's not until you really talk with the people who are, the end users, that it's important. And again, this can be, it doesn't necessarily need to be face-to-face consultations. It could be community kind of surveys or mail outs. But I think genuinely people like to talk about, their services in their community, and they want to engage. So yeah, I mean, I would just encourage anyone who gets the opportunity to be involved in any of these community consultations to do that and to really be part of that process.
Yeah. Yeah, that's the sort of consultation that certainly gives me a kick. Dario, you started typing something. Did you want to buy into a subject there?
Can you hear me?
Yes, we can.
So the only comment I offered, and sorry, I didn't mean to delete that question. It just moved it to the answered category. But I did make comment that the NCC actually does not require tactile surface indicators, ground surface indicators in residential aged care, because they are seen as a hazard, and that residents respond quite adversely to it. Be it through reflection or just it being a hindrance. So I just thought I'd make a note that sometimes less is more.
Yeah, I wasn't aware of that actually, but it's an interesting argument considering the average age of a patient in a hospital. Okay, moving on. Brian has an observation. I really like your comment that disability is a social construct. I believe that there is a real disconnect between minimum statutory requirements, NCC and AHDC, and aspirations to provide inclusive environments, and that the diverse needs of a range of people are not widely understood or acknowledged in the mainstream community. There also seems to be a lot of resistance at an agency level to undertaking deep engagement or proper co-design processes. So there's a very strong message for you if you're representing an agency. Okay, next question. Given the importance of stakeholder feedback to address universal design, how do you deal with holding your designs loosely, i.e. not becoming too attached to a direction? Interesting question.
Well, I think designing hospitals, it's a really complex task. There's whether it's a small facility or significantly sized acute healthcare service. I don't think you can get too attached to it, because you need to have that inherent flexibility, and you need to appreciate that as the design evolves, you're going to gather more information, and you need to be able to kind of respond to that. So I think that's just part of the evolving design process. I think I think there's certainly a place to be able to work with and educate and inform our clients about our thinking and where we have our intentions. But I think, ultimately, they are the end users. They need to be using this space. And so it needs to be fit for purpose. So we need to have that flexibility in our mindset about this journey, because, we need to retain that flexibility.
Yeah, I guess it has a lot to do, speaking as an architect, it has a lot to do with your design methodology. So I try to keep a design loose until I know the full gamut of information. But someone else might have a different approach. Have I missed something, Dario? Missed a question?
No, I think you've covered all of them.
Okay. Well, let's wind up then. Thank you, Leanne, for your presentation and insights. I think there's a whole opportunity for a broader national dialogue. Please, thank you to all attendees and the AHDC Events Committee for organising this evening. Please use this QR code on the screen to provide feedback and complete the CPD questionnaire. Announcements. I've asked for an update on this European tour, but I haven't got the information to give you. If you've been watching our social media, you've been seeing updates on it. So stay connected with our news for any further updates. Look at our LinkedIn page and subscribe to our monthly newsletter. We thank everyone for attending tonight's event, and we especially thank our sponsors. Let me get them up again. Foundation partners, In Vitro Technologies, Katingi and Enware, our industry partners, IPG and Steris. Thank you for all attending. We will now turn off the recording, and for those who want to dwell for further informal discussion, please hang in there. Thank you. We have to turn this open, don't we?